In the early days of psychotherapy, before licensure boards, managed care, or standardized documentation, treatment often looked more like a conversation between two people in a room, with no clear structure guiding what came next. Think Freud reclining on a couch, free association, no formal plan, no goals. It was just intuitive, but also ambiguous. Then came the rise of evidence-based practice, insurance oversight and accountability in care. Suddenly, the question shifted: how do we know what's working? Therapists had to justify their approach, articulate their goals, and track client outcomes. That's where treatment planning emerged, not just as a paperwork requirement, but as a cornerstone of ethical and effective care. One of the earliest frameworks that helped formalize this was the problem-oriented record system developed in the 1960s by Dr. Lawrence Weed. His method eventually influenced how mental health clinicians document problems, interventions, and outcomes, shaping what we now call treatment plan. Today, nearly every major mental health exam in every clinical setting requires you to master this skill. So, whether you're studying for a licensure or sitting down with a new client, a good treatment plan is no longer just helpful, it's non-negotiable. You're listening to Licensure Lifeline, the podcast that helps people toward licensure as mental health clinicians. I'm your host, Matt Lawson, and in today's show, we're going to be talking a little bit about treatment planning. Before we get started, just a reminder to check us out on Instagram. That's also one of the best places to write me notes, or if you have any questions, try to contact me through there, or write a review in the podcast, wherever you use to listen to the podcast. Not only does that help me better understand how I can support people, but it also helps people find the show. All right, let's check out what's in the news. In a recent update from the Centers for Medicare and Medicaid Services, treatment plans will now be under greater scrutiny for including measurable, person-centered goals and behavioral health documentation. So this change is reinforcing what we're already doing for licensure prep. So just pay attention to clarity, specificity, and progress measures when you do both your progress notes and your treatment planning. Something that we're seeing more and more over the last several years are insurance companies really paying a lot of attention to not only what is in the notes, but when notes are submitted. There's this thing called a clawback, which sounds really, really scary, and it kind of is, but insurance company can go back months into your notes and check to see if they were submitted in a timely way and see if they were done in a way that what they consider proper. So it's really important to just be up on what are the important aspects to that go into putting together a good note, to putting together a good treatment plan. Insurance companies can do things like just not cover the service, and that's kind of where the clawback comes in, is they can claw back their money. So it's good to just develop the routine, develop the habit around doing your notes either right after the sessions, really sticking to like a 50-minute session to give yourself the last 10 minutes just to do the notes. As just a way of doing and a way of being in therapy. In the study stack for this episode, it is pretty specific to treatment planning. So instead of flashcards, you can create SOAP note samples for imaginary clients using different diagnoses, just practicing how goals, interventions, and progress fits together with this model. If you're not familiar with SOAP notes, this is just one of the standards that's been created around treatment planning. SOAP is an acronym. It stands for subjective, objective, assessment, and plan. So basically, it really helps you just structure how you put in your treatment plan and make sure that these aspects of the treatment plan are covered when you submit it. All right, let's get into the main content around treatment planning. Treatment planning isn't just checking boxes. It's one of the more important aspects of ethical and effective therapy. If you think about, what sets therapy apart from really giving advice, this is one of the aspects that really sets therapy apart. you are channeling everything that you learn, both from school and from life, really, to help you create a treatment plan that is personalized to the individual that's sitting in front of you and can really support them in getting to an end goal. One of the criticisms that I hear a lot about therapy is people oftentimes feel like they've been thrown into a bottomless pit of treatment. And, you know, I think that there are moments for processing in therapy, but I also feel like there are moments of structure, and actually working toward a goal, working toward completion. And I think it can be very easily argued that, is there really ever a goal in for or an endpoint for good mental health? Or to be in a place with your mental health that is settled. I think it can be argued that people are ever evolving and there's different aspects of their lives. And yeah, like coming back to therapy again and again, throughout life isn't necessarily a bad thing. It's nice to be able to have that support. But when we're working with individuals, being able to look at what they're bringing to us, what they want to work on, what they want to address, and actually giving them a process to get to some type of resolution, to get to some place is important. It's I've seen people work with therapists for years and years and years and not really get to a place where they ever feel like they're done. And I don't know if that's necessarily the goal with therapy. People should be able to get to a place where they can feel like they're done. And I think that can take on many different looks, but with treatment planning, it can really help to structure toward an endpoint. So, what makes a good treatment plan? If you're familiar with SMART, the acronym SMART, SMART, specific, measurable, realistic goals. You know, Again, this goes into the treatment plan. Interventions tied to client symptoms and strength. So this is another reason, like when you think of an intake, you're not just listening to what's wrong with the person. You're listening for the symptoms, but you're also listening for the strengths. Again, this will help you personalize your treatment planning. And then what does a timeline look like? You know, it's not that you're setting an agenda as much as you're considering a realistic timeline to help this individuals. And oftentimes you'll see insurance companies come in and set those timelines for you. But thinking in terms of, based on what I know about this individual, based on what they've presented to me right now, what is it, what could be a potential timeline here? And then evidence for collaboration with the client. Um, you know, Being able to put in some of the other, again, personalized pieces that make the treatment plan unique to that individual that you're working with. It's really easy to fall into a place where you're going into each session and it almost feels like you're just going off the seat of your pants. You're having a nice conversation with the individual. During that conversation, like you're hitting on some of the points that they brought to you around like some of the issues that they're having. Sometimes the conversation completely goes off the rails, and next thing you know, you're talking about the NFL or something like that they like. But one of the nice things about treatment plans is before the individual even gets there, you have a structure in mind. And if you think about the notes that you're taking in each session, and how they relate back to the treatment plan, it really helps give some nice guidance. And when you combo those two things together around like, okay, where are we going next with this conversation? What are we talking about? What strategies and steps and techniques can I teach them in this next meeting in order for me to move things along, progress things forward? So it takes a lot of ambiguity out of what therapy is and really, again, adds that structure. Common frameworks, like I've already mentioned, you have your SMART goals, those specific, measurable, achievable, relevant, time bound. I've messed with this acronym so many different times. I worked in corporate America long enough to get really sick of SMART goals. So I've done thing like done things like just create different acronyms that basically mean the same thing just for me. SOAP notes, subjective, objective assessment plan. I've talked a little bit about those. Person-centered planning. You're going to see this more and more, and with like um, insurance companies, Medicare, Medicaid, but they want this person-centered type of planning. Again, speaking to the individuality within the notes. And then when you think of what you're going to see on the exam, um, in reference or different exams in reference to treatment planning, this is going to be where you're going to be identifying appropriate goals based on the diagnosis. So if you think of the NCMHCE, you're going to be looking at, what's presented, and getting good at picking out the goals based on the diagnosis, choosing the correct interventions that come up for each person, knowing when to refer out or even revise a plan, and then recognizing some of the ethical concerns um, that go along with working with the individual or that are coming up as you are working with them. All right, that is basically what a treatment plan is in a nutshell. I hope that's helpful. I would love to hear what you guys think about treatment planning. I know when I was going through school, this was not a fun thing for me. One of the neat things about AI coming out right now is treatment plans are going to be pretty easy to make with AI. I've already seen some of the newer software around both treatment planning and session notes. The paperwork for being a therapist is getting less and less and less, which is a very nice thing. If we can, anything where we can focus more on the person, more on the treatment, and less on the paperwork, and know that the paperwork is in a good place for insurance companies and things like that, absolutely, why not? Still, I don't want the tech to make anybody lazy. This is still a really great thing to hone your skills around, especially initially, so that you know what a good treatment plan looks like. Because, especially where the technology is now, it's, it can be kind of generic. So being able to speak to like what a good treatment plan looks like and what it isn't is going to be important and an important initial step. How about some questions? You might see some of this stuff on the NCE. First question: which of the following best represents a measurable treatment goal? Is it A, client will feel better, B, client will work on anger, C, client will reduce angry outbursts from daily to once weekly over 4 weeks? Is it D, client will express emotion? This is a pretty easy one. Answer here is C. So the client will reduce angry outbursts from daily to once weekly over 4 weeks. This is measurable. This is something that you can observe. It has all the aspects of a good goal for a person. Next question: what is typically included in the plan section of a SOAP note? Is it A, client's mood, B, diagnostic impressions, C, future interventions and next steps, or D, client's history? Correct answer is C, a plan that outlines upcoming clinical action. Next question: when should a treatment plan be revised? A, every session, B, when the client stops attending, C, at regular intervals or when goals are met, or D, only when asked by insurance. Correct answer is C. Plans are revised when clinically appropriate. This is an interesting question. When to revise the plan, and this again kind of speaks to long-term ongoing therapy. You can start therapy with somebody and hit your goals several sessions in, and then spend create new goals, and then the next sessions are about hitting those next new goals. Again, as you get to know the person, as they get to know themselves better through therapy, other things might come up, and you're put in a place where the goals that you had before may have come to a good spot, and you then kind of revisit, like, okay, then what's next for you? Where do you want to go next? And make a new treatment plan around new goals. Next question: Which of the following interventions aligns with CBT for anxiety? Would it be A, art therapy, B, cognitive restructuring, C, deep tissue massage, or D, narrative journaling? Answer for this one is going to be B, cognitive restructuring. Big old piece of CBT therapy for anxiety. Last question. A treatment plan must always be A, focused on the therapist's clinical opinion, B, directed solely by the client, C, created collaboratively between the therapist and the client, or D, approved by a psychiatrist. Kind of an easy one here. Collaboration, right? Collaboration is always going to be the key with the therapeutic relationship. You're not coming from a place of expertise as much as you're coming from a place of collaboration with the people that you are working with in therapy. Remember, they are the experts on themselves. You might have some expertise in psychology and mental health, but they are the experts on themselves. How about a vignette? Jordan is 24 years old, presents for therapy after a recent breakup. He reports feeling numb and unmotivated, sleeping 10 to 12 hours a day, and eating only one meal. He denies any suicidal ideation and recently stopped attending graduate classes. So let's look at provisional diagnosis here. I'm thinking major depressive disorder. What is the most appropriate initial treatment goal for Jordan? So remember, thinking measurable, thinking stuff that you can observe, that he can observe. So maybe increasing daily functioning to improve sleep and nutrition habits. What's a low-hanging fruit type goal that we can give Jordan kind of right off the bat? Then, let's start thinking intervention now. Which intervention fits this goal? So it might be something like establish a structured daily schedule with the client's input. So you can do this right in the office, right? You can start structuring what a day might look like with Jordan, giving them something that they can take with them out of that office and work on at home. What would be an ethical misstep in creating Jordan's treatment plan? Of course, doing this outside of collaboration with Jordan. Again, this is a mistake that I see a lot of people make. I kind of alluded to it earlier, but thinking that you're the expert, you're going to put this treatment plan together, give it to him, and he's going to be healed, right? So you always are going to be doing these things in collaboration with the client. It's not a bad thing to be like, hey, this is what I'm thinking so far. Take a look. Tell me what you think, what needs to be added. What needs to be taken out? What do you feel like is going to work for you? Next question. If Jordan shows no improvement after 4 weeks, what is the best next step? Pretty easy here, right? You're going to reassess the diagnosis and review how effective the treatment planning actually is. This isn't a bad place to ask Jordan about their thoughts around the plan. Maybe he's just not in a place to take on some of these things that are being suggested. And if that's the case, what are some lower level type things that might be better for him? All right. That is going to be it for the episode. Thank you so much for listening. It took me a while to learn to enjoy treatment planning. But it's a really great tool. It's a really great way to work with your clients and support them. And I hope it's something that you can just make your own and really learn how to best and effectively use this with the people that you work with. But thank you for listening. And until next time, keep learning.